please welcome Carescribr.
Hi, everyone. Just want to ask, anybody here a clinician? Can I have anybody raise their hand? One? Okay. All right, very good. So, my name is Troy Russell. I am the founder and CEO of Carescribr. I'm also a practicing physician. And I wanted to set the stage for this conversation we're going to have today. So fill in the blank. Anybody feeling gutsy to answer this question? That in a metro area, an increase of a single intervention per 100 or per 10,000 people reduces inpatient admissions by 5.5%, reduces outpatient visits by 5%, reduces ER visits by 10.9%, and unnecessary surgeries by 7.2%. I get it, it's okay, it's okay. Primary care physician. Surprising, huh? So, access and continuity with your primary care physician reduces morbidity and mortality. That among all the interventions in the last 200 years, continuity and one provider knowing your story and helping you navigate the healthcare system has a better predictor than almost any other thing. So why don't we ever talk about that? So when I went to medical school, 2009, we came in learning about the story of what it is to be a physician. How we spend time looking at the patient, understanding their symptoms, consoling the family members who suffer along with the patient. But when we hit the road, the tires hit the road and the physicians are actually graduating and out in the real world, we come with an inspiring vision of what we hoped medicine would look like. That since the ACA and the HealthTech Act, that we'd be able to bring amazing data, we'd be able to share our screen and review their data together to set a course forward for the best form of care for them. But this is what it actually looks like. That we sit on our screens, we spend more than half of my day typing information into a computer screen. And it's not because I want to. I don't have another option. But if I don't do it in the room, I'm already spending 2.5 hours in my evening finishing notes. There's not a lot of extra room to fill it. So, why am I on this stage? So I practice in Lynn, a couple minutes north of here. I'm a supervising physician for a couple providers. And I've seen the burnout. I see how it occurs. And back in March of last year, I had a provider come to me at the end of clinic and said, "Troy, I can't do this any longer." This was a social worker who used to work for Healthcare for the Homeless, one of the most passionate, empathetic, brilliant people practicing medicine, and ground down to the point where she couldn't go any further. But unfortunately, this is not equally distributed to all physicians. Frontline physicians feel it more than almost any other. And they routinely report EHR tasks, charting and paperwork, computerization of the EHR as the biggest culprits. It reduces access because their way of alleviating that burnout, reducing their clinical hours, leaving underserved patient populations, and going to easier situations. But instead of going straight to what I think is the best way to solve this problem, we went to the research, which shows that the vast majority of physicians' time is spent gathering data, documenting it, and then reviewing information. So the takeaway is that if any kind of intervention the authors of that paper said, should be ending the requirement for physician documentation and order entry, establishing an agenda beforehand, and a pre-visit plan to give an idea of what the patient wants to talk about so that the physician can then meld that with their own. Because anyone who's ever been in clinic, it may look like steps on an assembly line, but it actually plays out more like a dance, where the patient and the physician are talking to each other and deciding the way forward. So what is Carescribr? It is a platform application that alleviates that documentation by having a patient in the waiting room enter their information into a secure kiosk that is a cloud-based personal record that's interoperable and able to be transmit that record to any clinic. That establishes the agenda, sample screen, that allows the physician to see a tracking board of that patient's journey through the clinic. That takes all the clinical information and produces a clinical report that allows them to have a pre-visit plan. Simple questions, simple UI that a patient can understand in their own language, both English and in Spanish. That could easily be copied into any EHR, basically skipping over the human to digital translation, instead human straight to digital. And this is a sample of the agenda screen and the clinical report. So I'd like to show the actual demo. So the first screen that comes up is actually the idle screen, the screensaver on the tablet, which is on an iPad. So the patient then walks up to the screen and taps on it. They'll be able to, in this screen, decide, do I need to set up an account or do I have an account? If they have an account, they select it and then go on to logging in under their own username and password and a secure question. The beauty of the technology we're building allows for syncing of the cloud-based record to any kiosk in any clinic anywhere in the United States. The patient is able to determine the visit reason, which provider that they are seeing, be able to select the various reasons they came in, search among all the different symptom types, both in their language and their understanding, so that a cough that's from painful breathing different than a cough from chest congestion. That various demographic details can be then extrapolated to allow for prevention screening. And these are some different questions that I can show you to kind of understand the level of detail that the questionnaires ask. Up in the top right, it also shows the progress through the questionnaire. So patients get feedback about how much longer they have. The other part I'm most proud of is actually introducing the social determinants of health screening. Medicine is moving in this direction, but I've seen it in my own clinic, is that it's another task that the administrators are trying to add on top of what I'm already doing. So if we can cut them off at the task and collect it with the patient in the waiting room, even better. So this is a dashboard, the tracking board for those patients. And then within 2 clicks, it goes to the history of present illness. And this is the level of detail of the note. This is way more than what a physician could actually document in a 15-minute visit. This is evidence-based, peer-reviewed, in the patient's language, but could be easily dropped right into an EHR note. It has 2 versions, a narrative version and a brief outline, so that if a physician wanted to look for a specific bulleted list, they'd be able to populate it in a different format. Questions? Yeah, design it first.
You represent Columbia business partners around the world, many business partners of partnership. How do you work with the compliance once you reach out of state commerce, everything, information protection?
Similar to any other AWS, our partner with Healthcare Blocks essentially is securing all of the database. And so they're licensed and have all the framework set up to be able to do it across states.
Excellent. I understand the ability to take what you capture and put it into a record, but do you in any way pull information from the existing record? So if somebody is known to be diabetic, suffers from hypertension, has reported the same symptom 4 times in the past 5 years, that you either show that information or change the questions based on that?
We will be going in that direction. The current MVP is simply data collection from the patient in the current state, but we will be moving in that direction, actually, yes.
Last question. So how much time is this actually saving? Is this increasing the number of patients a physician can see or just reducing it?
Well, so hypothetically that is possible, but that's not the goal. The goal is in a 5 to 8 minute window that a patient can fill it out in the waiting room, saves the physician about 3 to 5 minutes in the exam room, which is, in my current situation, 30% of my visit. So that would be a dramatic increase in time to talk about treatment plans, to reinforce and answer questions. That's the eye contact that would allow me to have with patients that they would really value. So 5 to 8 minutes in the waiting room, I think patients are going to understand and see that value.
Thank you.
Thank you.